Are you guys all ready for the online class to be over?
Yes.
Yes. But you'll also miss it a little?
No.
Yeah, so your final is Wednesday. So hopefully you're all aware of that and ready. For the online?
Yeah,
For the final?
some readings that we have that we want to kind of relate to the
Concept?
category of like delegation, prioritization. So, just a minute clarification on you and what we're actually beneficial for review on.
All right, getting into the routes of administration. So your book has it kind of confusing, but there's really just 3 categories of routes. Okay, one is oral. Okay, that's the main one that we use. We give pills. It also includes if we gave a sublingual, like something that would melt, like our nitroglycerin that we've talked a little bit about, or a buccal, which is kind of like a cough drop or a lozenge type medication. Okay, so anything that dissolves in their mouth or that they would swallow would be the oral route. Okay, the second category is parenteral, which includes all of our injections and IV. So sub-Q, intramuscular, intradermal, and intravenous. Okay, so those all fall under parenteral. And then the topical category is the one that's most confusing because there's so much under it. It is skin, so any lotions or patches or ointments, powders. It's also eyes, that's also included in topical, so eye drops or eye ointments. Eardrops would be also topical. Nose, like Flonase is a common one for allergies, an inhalation medication. And then any of your handheld inhalers, like albuterol, or Symbicort, or if they are hooked up to a nebulizer and they have the mask and it takes like 10-15 minutes for that medication, that's inhalation also. That's all considered topical. Okay, and then any suppositories, rectal or vaginal, again, it's all topical. Okay, so if you think of the mucous membranes as a continuation of the skin, then that'll kind of help that make sense to you that those are considered topical. Okay, so those are the 3 categories: topical, parenteral, and oral. Alright, so going through and talking about oral medications then, it's usually there's pills or tablets or capsules. It just depends on like how they're made and how they're put together. But your patient should be awake and alert and they should be able to swallow. They should not be NPO for any reason, for a test or for their medical condition. You can't give somebody oral medications if they're vomiting, because they're just gonna vomit them back up. And then hopefully it's obvious to you that you could not give an unconscious patient oral medications, okay? Because they're not gonna be able to swallow them. Okay, so a few parameters there for your patient to be able to take oral medications. And then again, the tablets or the capsules or the pills, just different ways of saying an oral medication. Okay, and then specifically, some drugs are enteric coated. We talked a little bit about this yesterday. It just means that when they're put together in the lab, there's like an extra special coating that it takes longer to melt or dissolve or break down in the body. So that would be enteric coated. Specifically, we do that if the medication is going to be irritating to the tissues in the stomach. So we want it to be able to wait until it gets into the small intestine to break down. Or if just the makeup of the drug is found that it works best if it is absorbed in the small intestine or later on in the GI tract. Okay, so the scientists can add those little extra layers and make sure they know where it's going to dissolve or break down. Okay, some letters here that you need to know what they mean. SR means sustained release. So it would be, these letters would be after your drug name. So it would be like metoprolol SR. Okay, so you'd have the name of your drug and then you see these letters and then that tells you that you cannot crush or break this pill. Without even knowing what it is, if you see any of these letters, you know that you cannot crush or break it. Okay, so sustained release That just means that as your body lets it go through your system, it takes longer. It's not a quick release, it's a sustained, a slow release. Okay, and then extended release, it's gonna be the same type of thing. Controlled release. And then the SA is a sustained action. Okay, so just all different letters for a way of saying that it's supposed to be slowly broken down and absorbed in the body. If we crush it or break it or manipulate it, then we're gonna defeat the purpose of that special coating. Bless you. Right, in addition to the pills and the capsules and all those things, there's liquid medications that we can give. In the nursing home, you're more likely to see the multi-dose big bottles of things, and then the nurses will divvy that out in the med cups for the patients. In the hospital, they'll come up in little individually labeled and barcoded medication cups with their liquid. So elixirs and suspensions and syrups are just different ways of saying just a liquid medication. And then as we're giving our medications, we are going to use disposable med cups. The one that's pictured is a disposable calibrated cup. That means it has measurements on the side, the plastic ones, and then you might also see the paper ones that don't. They're not calibrated. They're just little paper med cups. Okay, so for that, with that plastic one, we could do tablets or we can do liquids. And then for some liquids, you might see like a plastic oral syringe. If you have kids, maybe you may have used those at home if they've ever been sick and you had to give them something. Okay. And then some special techniques for giving our oral medications. So again, just always make sure that your patient is alert, awake, sitting up. You had them like drink some water maybe, so you know that they're not gonna choke. You could, by spending time with them, and then maybe you won't figure it out until you give the meds, you can kind of see, is it gonna be, some patients will take a cup of 15 medications and just throw them back and swallow them. Other ones, if you try to hand it to them, they'll just like drop it all over themselves. So you just kind of gotta figure out how much help, if any, does this person need. Some of them, so have a spoon handy. So if your patient's like really like weak or has limited dexterity and they can't see and it's a whole process, it's helpful to have a spoon, because then you can just spoon out one or two, put them in their mouth, and then they can drink, okay? And then always have a bunch of water ready to go. So we do all these checks, and we go in with all their meds, and we start the process, they have nothing to drink, or they have this much to drink. That's gonna take some time to go get more stuff. So make sure they have plenty of water to swallow that down. And then, like I said, sometimes we have to crush them or mix them. Yep.
What if you go to give them oral medication and then all of a sudden they're just not able to swallow anymore?
All of a sudden.
Like,
Are they having a
we're
stroke?
not able to just.
Yeah, so if that all of a sudden happens, that's crazy. Something's happening. So you would have to do an assessment and probably get somebody else in there and see what's going on. But yeah, maybe they haven't been taking many medications, or maybe they haven't been there very long and you're the first one going in and they have a vitamin due or something and they can't swallow at all. And their breakfast tray is just sitting by them and they haven't touched it. You know, depending on who admitted them and what was going on that night, you might come into that situation. So then, you know, you'd probably have to put them NPO. The provider would, after you let them know. They'd probably have a speech therapy consult. So in the hospital, if your patient can't swallow or has any trouble, it's speech therapy. So they're much more involved in the hospital than they are in the nursing home. They'll see a lot of our patients. And so they'll recommend if they need to be on like special mechanical ground up food or special thickened liquids. And then they'll come in and do exercises with them every shift, and then they'll let you know when it's safe for them. But yeah, so always check. Make sure they can swallow. If we're crushing and mixing, they usually will pass that on in reports. They have their meds crushed, and they like it in pudding or applesauce. Those are the two main ones that we use. And so we would do that, mix it all up. For your patient, technically the right way to always do it was to crush them up individually. And so you'd have like maybe 10 things of crushed up meds mixed in their stuff. But a lot of times now we'll get an order that it's okay to crush the meds together. And then as long as there's none that like shouldn't be mixed together, if you have that order, then you're good. You can put them all in the thing, crush them all together and mix them all up together. So you just have to check and once we start talking about tube feed. So if we have to make them liquid to put in their tube, like that's in their stomach, sometimes we say you have to have them all separate, or sometimes it'll be okay to mix them together, it just depends. Alright, the water we talked about, and then making sure that they have their teeth brushed is always good when you're taking care of the patients. And then for older adults, like we said, sit them up, maybe have a spoon to help if they are having limited dexterity. They're gonna be a little bit slower. Sometimes we can do it or we can tell them to do it, but if they go like this to their neck while they're trying to swallow, it helps kind of prevent them from choking. And then just with every patient as we're admitting them, and then again as we're discharging them out, for all patients, we wanna make sure that they use one pharmacy, just so we can keep everything on, keep track of everything. If they use a bunch of different places, maybe they're getting duplicates or missing things, that's very unsafe. So they should just use one. And then with all patients, as we're giving medications, I've kind of talked about how in-depth we get with teaching. So first we want to ask them, do you know what this is? Do you take it at home? A lot of times they'll be able to tell you, and you just go from there and see what they say. Maybe they'll say, I don't know and I don't care, and then you'll just say, well, I have to just tell you what it is as I go, and then you'll just kind of name them off. Most of your settings in the hospital, your patient's bed is here, and then their computer is usually right up here by the head of the bed, right here. And you're at the computer and you're scanning things and you're getting ready to go. Do not stay at the computer, at the keyboard to open all your medications, okay? Because you will drop them all over the place. Make sure that you take the time, go to the patient's bedside table so you have plenty of space to open up all of your medications. Make sure you do that. All right, contraindication then is going to be if they're NPO. So for an illness or maybe for a procedure that they have going on, mild nausea, sore throat, if they're ANO, all that would be okay. But if they're NPO. So if you're assigned a patient who's NPO and they have medications due, as the RN, they would be communicating with the provider and saying, they're NPO, these are their meds, this is what they're supposed to have done. Do you want them to have any of these anyway with just a sip of water, or do you want to hold them all? Okay, you as the student, you would have that conversation with the RN, and then they'll tell you what the doctor says. Okay, so we just need to double check on that. Okay, due to its coding, it's going to be an enteric coded tablet. Enteric. Okay, that's going to be extended release or sustained release. Liquid medications, that disposable calibrated, which just means it has the measurements on the side, or a plastic oral syringe. Okay, good. The only one that makes sense is B. So it sounds like something simple, but you'd be surprised how many students come get me and we go in there and then they have nothing to drink. So make sure they have plenty of water. called polypharmacy, so when they're taking like many medications, just need to, there's just lots of risk factors there. All right, talking specifically then about if we're giving medications through an enteral tube. Okay, so we said parenteral was IV, IM, sub-Q, IV. Enteral is through a feeding tube in your gut. Okay, so it's either just directly through your stomach or temporarily you can have one through your nose down to your stomach. Okay, the ones through your nose down to your stomach can either put stuff in, or if you have a blockage, it can be a different kind of tube and it can suck stuff out. Okay, so either way. But for feeding tube, I'd be putting stuff in. Okay, so if your patient has a PEG tube or an NG tube and we're putting things in it, they should be liquid. Okay, that's the best practice. We have the technology, we have the medications and the nutrition and the different things, it all comes in liquid. Okay, so, but depending on your facility and what supplies you have, you might not have that. Okay, but if you're putting stuff in a tube, it should be liquid. Sometimes we don't have that and we'll have pills that we have to grind up into a powder. Okay, so a capsule or an enteric coated, we can never do that. Just your regular pill, regular tablet, we can grind those up into powder and then we would mix them. So when we do that, we mix them with 15 to 30 milliliters of liquid. And some facilities will use like bottled waters and different things, but most just use tap water. So because it goes into your gut, into your stomach, it doesn't have to be sterile. So we would just use like room water for mixing medications and for flushing it. There'd be equipment set up in that patient's room. They'd have the graduated cylinder in their room. They'd have the TUMI syringe, that big 60 milliliter syringe. They'd have some other cups and equipment in there, and they'd have that ready to go for that patient. So if we do have to mix up a pill, we grind it up, and there's pill crushers that we'll see once we get into our hospitals. And we'll put it in a med cup, and we'll add 15 to 30 mLs of water. I usually like it a little bit on the warm side, not hot, but a little bit warm because it's gonna help you break up your pill and dissolve it. So if you look at a med cup, all med cups are 30 mLs. So it would be either a full med cup or a half med cup. 15 to 30 is what you would mix it up with. So if you have 5 pills, you have 5 med cups like that, all set up with 15 to 30 mLs of water all ready to go. Okay? Again, most places have what you need. Mostly it's labeled, they'll come in individually packaged little things. Anymore, we're not really having to do all this jazz. Okay? So again, room temperature, or if you're trying to dissolve some medications, a little warm, and then by the time you get it over to your patient, it's not gonna be as warm anymore. When we're putting stuff in their tubes, even though they're not sitting up and eating, it's still like the same process, so they have to be sitting up. If we try to put stuff in there, or if they had like a continuous tube feed running, and we laid them down, they would choke and die. It would all back up, and they would choke and aspirate. Okay, so we have to have the head of their bed up while we're putting anything in. And then the most important thing is to always check placement. So we can't just go and say, oh, you have a tube feed, cool, I'm gonna put this stuff in it and call it a day. We always have to make sure it stayed in the same spot. And with a PEG tube, it seems kind of silly because where is it gonna go? And it's not ever gonna move. Your PEG tube's not gonna move, but we still have to check it. With an NG tube, it makes more sense because that can move. If it comes out a little bit, then all of a sudden you're not all the way in the stomach, you're up in the esophagus. What's right next to the esophagus is the trachea. So if it gets displaced and comes up, you could be infusing tube feed, and then it can go into their lungs, and then they get aspiration pneumonia, and you'll see that happen with your patients. Okay, so either way, if it's an NG tube or a PEG tube, we have to check placement first before we put anything in it.
With those, isn't that why they always mark it sometimes, like the line or something, to make sure?
Yeah, so with an NG tube, that's one of the ways that you check placement. So when it's put in, and we put those in, I think it's a check off for you next semester to put an NG tube in. That's a fun thing to do. So when we put them in, you note, they have measurements on them, so you would say, right out of my right nares So you would note that in the chart. And then also sometimes they'll measure the external length. So they'll say, the 22, you can see it here, but then there's 11 centimeters of external tube length. So those are two ways that you would verify placement. So before I go to put something in it, that's what was previously documented, that should be what I get. If that's not what I see, then I would let the provider know, we'd have to do more assessment, maybe go do an x-ray to see if it moved. We'd have to mess with it. Okay, so we note the length, we measure it, and then what we always used to do, and what we still do, but what your textbook doesn't like you to do anymore, is that we would just get our stethoscope and we would put it over their stomach, and then we would take that 2 syringe and just pull back so it has some air in it, maybe like this much air, and then we would push it and you could hear that whoosh. So I said don't put anything in it, but air is okay. Air is not gonna hurt anything. Don't put water or like medications in it. So we would push that air in and we would listen and you can hear it, and that would be what we always did, but they say that's not accurate anymore. So we do that, and then after we do that, we pull back and we check what's called the aspirate, that's what's left over in the stomach. So that's another way of verifying. So as we pull back, we should see stomach contents, should be like green, brown, yellowy, clearish. So we look at that. We also have to measure it. So as we pull back, there should just be a little bit, maybe almost nothing, maybe a little bit, maybe like 30 milliliters in there. But some patients, they don't tolerate their tube feed, or maybe it's been administered wrong, and you'll go and do all your checks and you'll pull back and you'll never stop, and that whole 2 syringe will fill with stomach content. So now you have to go and put it into your little cup that you have that you're working with and save it, go back and pull again. And you have to keep going until you can't pull any more out. If there's over 250 milliliters, then that's bad. They're not processing it well. You need to notify the provider. They'll have to probably change their orders. If it's less than that, you're okay. You just put it back in. Either way, you put all that back. You don't flush it down the toilet or anything. You put it back after you're measuring, you put it back in the patient, because if you don't, it will throw off their fluid electrolyte balance. Okay, so you measure it all and then you put it all back in there. So that's another way. Another way is when we pull that aspirate out to look at it and check it, and this is what you'll do for your checkoff at the end of the semester. You'll have a little med cup with a pH strip in it, and you'll just put a little of that stomach contents in your med cup, and you'll measure the pH, and it's supposed to be acidic. That's what your book likes, and that's what NCLEX likes. I have yet to see that anywhere, though, the pH strips. I don't see that. So those are all ways. So there's lots of different ways to verify placement. Okay, so we need to do all those things and make sure it's in the right place. And then once we're good to go, we can flush it, put in beds, put in tube feed, whatever it is. Okay, our pen tube, again, where's that gonna go? That's not gonna change, but we still wanna do our abdominal assessment and bowel sounds and all that. NG tube, we are worried about, because if it comes out some and we're putting stuff in, they could choke. Okay. That. And then, so if they have an NG tube, I said they can be for suction or they can be for tube feed. Some people will have it for both, which is weird. And so we'll just like take breaks from the suction to use the tube to put things in. And then in that case, we would just have to leave their suction off for like 30 minutes. Otherwise, we're just gonna suck out everything we just put back in. Okay, so sometimes you will see that. And then just like all of our patients, but especially if their nutrition is altered, we need to maintain their intake and output, just document, keep track of it. And then I just have X's on her hands because we do have to have gloves, because that's blood or body fluids, right? The stomach contents. And usually those tubes will like backflow all over the place. The tube should have a clamp on it that you can control, and then some of them also will have a cap. But then again, also you want to have chucks or like towels laid on the patient anytime you work with those, because you never know, they'll just start leaking all over. Alright, and then a picture of our sublingual or buccal medication, so below the tongue or in the cheek pocket. Okay, your patient has to not have a really dry mouth to give this. Like if your patient's mouth is super dry, you'd wanna have them drink some water, maybe suck on an ice cube for a while, because if their mouth is super dry and you put a drug in there, it's not gonna break down and dissolve or absorb or do anything, because their mouth is too dry to tolerate it. Okay? Okay, so common ones, the one is the emergency medication, the nitroglycerin. We talked about that. You can give it every 5 minutes for up to 3 times, as long as their blood pressure stays tolerating it, because it's a vasodilator. You give it in emergency situations for chest pain to prevent heart attack. So it vasodilates so that your heart can get oxygen, but then on the flip side, the rest of your body is dilating, so your blood pressure drops. Okay, so nitro is the most common one. And then the other one is a drug that we're starting to talk about, Zofran, or ondansetron. Zofran is a really good antiemetic, or med for nausea. And so they'll get it if they have nausea, or a lot of patients who take pain medications, they make them nauseous, so they'll get the Zofran with their pain medication, so they don't get nauseous. But we give it IV push, but it also comes in an orally disintegrating tablet, so we might see that. Alright, topical medication, so we've got all these topical, and then the next slide is inhalation, but I just wanna make sure it's clear, inhalation is a topical medication. It's not separate, it is topical. Alright, so, topical medications, like I said, it's skin and the mucous membrane, so including your eyes, ears, nose, all of that. These medications are not shared among patients. Once they have a vial of eye drops or ear drops or nose spray, it's theirs. It's labeled. In the hospital, it either stays locked in their room or locked in the Omnicell. Okay, so it's just theirs. If we're doing a topical cream or patch or lotion, we always need to wear gloves to apply it, because it can be absorbed through our skin just like it is through theirs. We always need to check and see if there's an old patch or area with cream or something that needs to be removed first. So usually that's its own documentation as well. So on the MAR, it'll say, 9 o'clock remove patch, 9:01 apply patch. So you'll document both parts. And then we wanna make sure that we rotate sites. If it's a patch, that can be put in different areas. Don't go right over the same site every time, because it cuts off the air supply, so we can create a sore in that area. And then just always making sure that the spot that we choose is clean, not super hairy, so that the medication can actually be absorbed and not irritated. Okay, common sites that we see patches are gonna be the chest, up here, or the upper back, shoulders are the main ones. We'll see nicotine patches in the hospital, pain patches, if you have like a long-term, like bad pain, like maybe cancer pain patient, pain patches. Nitroglycerin comes in all different forms, it also comes in a patch. What else? You can see, like there's anti-Alzheimer's medications that come in a patch. Anti-nausea, scopolamine, has anybody ever taken that? That comes in a patch. So we'll see all different types of patches. Lidocaine, I know in the nursing home, some of our patients have that. Lidocaine patches, you'll see fentanyl patches. And any patches that we remove, there's a special patch disposal bin in the med room. So we don't just put it in the trash. Wrappers from drugs that we open, like pills, those can go in the trash. But patches themselves have to go in the med room in the special bin. And then any syringes that we use have to go in the sharps container. Even if it's just the syringe and not the needle part, everything has to go in the sharps container. Alright, so that's skin. And then eye, we'll see eye drops, anything from just like artificial tears for dry eyes, or like glaucoma medications, so medications that will lower the pressure in their eyes are some common ones that we'll see. And we know that we wear gloves and we pull down on their cheek here to expose that lower conjunctival sac, and then we gently drop the liquid medication without touching the vial to the patient's eye, so it doesn't contaminate. Okay, and then we'll have them close their eyes so it can kind of absorb, have a tissue available start from the inner and do just a little line, a little ribbon of ointment to the outside, and then have them close their eye for a little bit. Okay, in addition to artificial tears and glaucoma medications, maybe they have an eye infection, so it could be like an antibiotic ointment. So just before we would do anything like that, make sure their eye is nice and clean. Get like a warm washcloth. If there's any like drainage or anything, you wouldn't want to put medication on top of an eye that's all gooped up. So make sure it's nice and clean. Okay, and then eardrops, more likely is gonna be an infection if they have an ear infection. And just remember for that, we would have them lay on the unaffected side, so the affected side is exposed, and then we pull the pinna up and back, up and down. And that just straightens out the ear canal. Alright, and then, nasal is most likely gonna be a spray. Flonase is the most common one I see. And we would just have them like block one side and breathe in while they spray on the side that they're using. Sometimes it's just one, others they'll do both sides. Sometimes patients can do this on their own. If they can, I would have them do it. Otherwise, then you would do it for them. And it just takes some coordination because they have to inhale while you're squeezing the medication, or they're not gonna get any of it. So that's nasal. And then vaginal creams or foams, you won't see as much. Occasionally, I'll like happen to have a patient who's there for a medical reason that has like an infection of some type, and they would get a vaginal suppository. Otherwise, it's really more of like a specialty niche if you work in women's health. But you would just position them on their back in the lithotomy position. Same thing as a rectal suppository. You would have gloves, have them take a deep breath. Usually, there's like KY jelly or lubricant that we use for those types of medications. Have them take a deep breath and then insert. And when we insert suppositories, your whole finger goes in. So you'd have the area ready. This medication is on the tip of your gloved finger, should be lubricated. You put it all the way in, and your finger goes all the way in to make sure that it gets all the way past any valves or sphincters, and then it stays in place, and then you pull out. And then you would keep them in position for a little bit to let things settle. If it's a suppository, we do the same thing for enemas, right, as we're administering enemas. So if we do an enema, for sure you would want them to stay in position for as long as they can tolerate, so that medication can work and do its job. The rectal suppositories that we'll give would be Tylenol, like if they're vomiting and they can't take anything orally. We do have IV Tylenol too, so we don't see it as much. But the suppository we would see is Ducalax. So Ducalax is an oral med that they can take. It's a laxative. It also comes in suppository form, and it's for constipation. Okay, if we're giving any suppositories though, that is invasive, so we just have to be aware of some complications. So if they have thrombocytopenia, that is just a fancy way of saying that their platelets are low, so they're at risk for bleeding, so just be careful. And then neutropenia means that their white count is low, so again, if we're invading their mucous membranes, they can be at risk for infection, so again, just be cautious of that and be careful. And then for cardiac arrhythmia, because your vagus nerve runs all the way through your body, and you can stimulate it rectally, and then it can make you go bradycardic and then tachycardic and then pass out. So you may have had this happen sometimes with patients in the bathroom if they're constipated and they're like straining really bad, and then they say they have a vagal response and they pass out. It's because they've strained so hard that they've stimulated that nerve. It makes you go bradycardic and tachycardic and then pass out. So just be aware of those potential complications. All right, and then inhalation. So again, this is still considered topical. So if you think of your respiratory system as your mucous membranes and continuation of your skin, that'll kind of help it make sense to you. But again, this is topical. Most inhaled medications that we give are bronchodilators. So they're gonna expand and open up the airway. So this would be for COPD patients or like people who have asthma, where the airway narrows and they have wheezing and shortness of breath. So bronchodilators. The other type of medications are steroids that we would give. So it's gonna decrease inflammation. are the main ones that we see. They could take 1, 2, 3, 4 different types of inhaled medications, depending on what's going on with them. They could take a combination of the handheld inhalers and the nebulized medications. It just depends on what's going on with them. MDI stands for a metered dose inhaler. That's these two over here. And then the DPI is the dry powdered inhaler, like your Advair Discus. Okay, so these ones, they're simple. You just take the mouthpiece cap off and they just squeeze and then the medication comes out. The dry powder inhaler, it's like 2 more steps. You just slide open the disc and then you pull this lever and it crushes the dry medication in there and then they inhale it. Okay, and you have those in lab that you'll get to practice with those. And then something a lot of patients need is that spacer. So again, like the nasal medications, it requires some dexterity and some timing. And if they don't breathe at the right time, they don't get that medication in. And so what's the point of doing it? They didn't get it at all. So we have a thing called a spacer, and that holds the medication in there for them until they breathe it in. So you'll squeeze and activate your medication. It just sits in there, so this will like snap into one side of the spacer, they'll squeeze it, and then the medication just sits in there until they breathe it in with however many times it takes. Okay, so they'll get the medication. So that's a good like monitoring point and teaching point for your patient, because this is like a life-saving critical medication. If your patient has this order, they really need it, and not getting it is really gonna affect how they're doing that day. And it's often overlooked, like we just give it to them and say, here, take it. And how many times is it just, they're barely squeezing it or they're barely getting it. So for sure, if your patient has this, make sure that they're taking it like they're supposed to and getting all that medication. The nebulizer then, they come in these little foil packed vials, and we just twist these open and then empty it into the bottom of that chamber. And then the mouthpiece comes apart. You can see a mouthpiece like that or a mask, it just depends on patient preference. And they usually take like 10 to 15 minutes, the patient will sit and breathe in. Again, check on your patient. If you go in and this is laying on the bed while it's running, it's not doing them any good. So we have to be vigilant, monitor, make sure that they're getting the medication. If they do have any of these, it's important to try to get your lung sounds listened to before they take this medication, and then again after, so you can see what the difference is. And then lastly, with any of these, we wanna make sure that we take care of the equipment. So rinse things out, put things away where they're supposed to go. And then your patient is supposed to rinse their mouth with water after using any type of inhaled medication, just so the drug doesn't sit on their mucous membranes and irritate their skin, but also it can lead to thrush, which is an oral infection. Okay, so always rinse. In the nursing home, the nurses give these medications. In the hospital, it always changes, but right now in the hospital, the respiratory therapists are doing the nebulizers, the nebulized treatments, and then the nurses are giving the handheld inhalers. Alright, so we did oral, and then we did topical, so then the third and last category is parenteral. Okay, so that's gonna be our injections. So here's just some vocab, a breakdown of our equipment. So here is the barrel of the syringe, or like the main part of it that's gonna hold your medication. This part here is the plunger. They say you wanna avoid touching that internal part that goes like inside and comes back out. Just overall, you wanna minimize the amount of time that you're holding and messing with your syringe. Okay, you can see they're all gonna be calibrated differently, so to know how to use your syringe, you have to know, you'd have to know that this is a 3 ml syringe, and then each little mark, since this says 2.5, you would know each one is 1/10 of a milliliter, right? So below that would be 2.6, 2.7. Okay, so you have to know how to read your syringes and be able to choose the right one. And then you have the tip here, and then the hub of the needle, so that's where it would come apart, or you would connect it back. Not all of them come apart like this, but a lot of them do. so you can change out your pieces. Most of our needles now, within the last 10 years now, will all have a needle protector. So once you activate that, it's over and you can't use this needle anymore. So in lab, you're gonna do a lot of like fake, like pretending like you're activating it, which you won't. But once you give a shot, as soon as you pull it out, you just flick that needle protector and it covers and locks that needle so that you can't stab yourself. Okay, the needle itself, we need to keep sterile, so we shouldn't let it touch anything except the patient. And then all of the needle edges are slanted, there's a bevel, so it's angled. Okay? And then over on the other side, all that's pretty much the same, only this one, here, these hubs just pop on and off, whereas mostly what you're gonna see in the hospital is what's called a lure lock system. And it pushes and twists, so there's threads to it, so your devices will thread in. Okay, and then you would also use this lure lock syringe to give an IV medication. So like if I had that full of an IV medication, I would just take it to my patient's IV, I would clean off their IV with alcohol, or if they had those swab caps that we talked about before, I would just take that off. I would have gloves on for an IV medication because there is a chance of blood or body fluids coming out. So if I pull back somehow, maybe the chance is low, but there is a chance. So then I would just take the edge of that syringe, push it onto the end of my IV, twist it, and then it locks right in place. Okay, so your IVs are all lure lock systems as well. And then all the ports on the IV tubing are also lure lock ports. So you can just take your syringe, push and twist it, and connect it to any of the tubing sites. Okay, so that's the basic breakdown of the equipment there. There's different needle lengths that are gonna sound confusing at first, but just like a head-to-toe assessment, these don't change. These are the ones that we use, and so they'll start to sound more familiar. If you look at the top, that's got needle length, and it's got what we would use for intradermal, which intradermal was your TB test. So it's just in the skin layer, so it's very superficial. It's just like a 5 to 15 degree angle. It just goes in the layers of the skin, intradermal. So at most, that's gonna be less than an inch, just a little more than half an inch. You can see that red line at the top. It would be 5/8 of an inch. Okay, and then your subcutaneous injection still is not gonna be more than 5/8 of an inch, but it doesn't get as short as the intradermal. Okay, and then the other one is your intramuscular, which is the longest. It starts at 5/8. So if you would wanna remember 5/8 would be appropriate for any, for intradermal, for subcu, or for intramuscular, depending on your patient. Okay, but that would be a good starting point, like 5/8 is about the average length of a needle. Could get smaller, could get a little bit bigger, but it's a good starting point. Okay, it goes up to 1.5 inches. That would be like a super muscular bound person that I'm giving an injection to, that I have a lot of tissue to go through. Okay, so there's a little bit of range there of what's correct. It's what is gonna get you to the desired location for giving that drug. Okay, so you just have to know your patient. If they're really tiny, you always wanna use the shortest needle possible. You wanna be nice to your patients. Okay, so that's needle length. And then we also think about the gauge, which is how big the needle itself is. So how big the hole is, the needle gauge. And then just like 5/8 is a common starting point, 25 gauge is common, and it would be an appropriate gauge for any of your sites that you're going for, okay? And then the gauges work backwards. So a 25 gauge is smaller than an 18 gauge. Okay, an 18 gauge is gonna be big. Okay, so our IM injections that go into the muscle can be 5/8 to 1.5 inches long. It can be an 18 gauge all the way up to a 25 gauge for down. And then our subcutaneous could be a 25 gauge down to a 31 gauge. Okay, and then intradermal is gonna be tiny, 25 to a 27 gauge. Okay, so just have a general idea, 5/8 and 25 are the numbers you should kind of be thinking about. And then it's not like you go to the med room and there's 50 different options to choose from and you have to choose the very best perfect one. There's gonna be 2 or 3 of what you use on that floor for what you do, and it's gonna be the same every time. Okay, in lab and check off, again, you're just gonna have what you need. It's not gonna be a million different options. Okay, and then just make note of your angles here. So like we said, intradermal is very shallow, 5 to 15, because we're just going in the layers of the skin. IM is always 90. Okay, so it's always a straight 90-degree angle, no matter what. The subcutaneous one is where we have a little leeway. It could be 90, it could be a 45-degree angle. It depends on our patient's build and their adipose tissue. Okay, so if I'm giving a subcutaneous injection, so the subcutaneous ones that we give are insulin, which you're not gonna give till next semester, and our blood thinners. So our heparin and our Lovenox, our blood thinners, we give those. We'll give those this semester in clinical. They're subcutaneous. Okay, they usually go in the belly. Okay, our insulin or other subcutaneous one can go in the belly or a lot of times in the back of the arm. Okay, so our main places that we're ever giving our subcutaneous injections, which are insulin and blood thinners, is the back of the arm and the belly. Okay, so if I have a patient who is very, very fluffy and I'm going to give it in their stomach, I can go in at 90 degrees. I don't even really have to pinch it. There's plenty of tissue there. I'm gonna get the right spot. I can just put my hand here, go right in at 90 degrees, push it in, and I'm good. Okay, if my patient does not eat and they're wasting away and they're very scrawny and I have to go in and give it in their stomach, I'm gonna go in at 45 degrees. I'm probably gonna pinch up as much fat as I can find so it doesn't hurt them and so it doesn't go all the way through to their muscle, even their bone. I'm gonna pinch it up and I'm gonna go in at a 45-degree angle. Okay, so the sub-Q, 45 or 90, depends on your patient. Okay, but IM is always 90. All right, this is just gonna be kind of repetitive of what I just said, see if I didn't miss anything. So yesterday we talked about rates of absorption, talked about how IV is immediate, and then after that, IM is the next fastest, and then third after that is subcutaneous. Okay, there are some blood vessels going in through there. Okay, so it's slower than IM, slower than IV. Again, what I just said, what we're giving subcutaneously is insulin, which you won't give till next semester, just because of the timing with it. It is a high-risk drug. A lot of your patients get orders for insulin AC and HS, which is before meals and at bedtime. So it's 4 times a day. We get their blood sugar. Depending on what their blood sugar is, they have like a scale that you just plug it in. Say their blood sugar is 300. According to their scale, for 300, they get 7 units of insulin. So everybody has different scales. So there's a lot that goes into it. So for first semester students trying to figure stuff out, we don't want to miss stuff and miss getting them their insulin before their meals and delay that. So that's a second semester thing now. But you will be taking your patient's blood sugar in the hospital. So that first step you'll be doing, and then you'll watch the nurse do the insulin, okay, so that you're ready to do it first thing next semester. Okay, so insulin, and then heparin or Lovenox are blood thinners, or what we're giving. If we do the arm, it's the upper arm, back in this like fatty area, and then abdomen, like I said, is the other spot, always away from the belly button, avoid the belly button. In the hospital, it's not a big deal, but if they were like a home patient or up and doing things, we would avoid the belt line, just because it's gonna cause like trauma and pain. In the hospital, it's really not a big deal. Okay, other areas, if they're a patient that gets insulin and they get shots like all day, every day, they might want some variation. So the thigh we can do for insulins, and then the upper back. So like if you've ever had allergy testing, they do it up on your back. Okay, so those are the other 2 areas. Not as common, but you might have a patient who says, yeah, go ahead, let's do my leg today. I've had enough of my belly and my arm. Okay, like we said, we wanna avoid any sites that are bruised, if it's painful, if it feels like weird and hard, like there's tissue changes going on, if it's swollen or red, or is like old, scarred, damaged tissue. We don't wanna go on that site. We wanna rotate, like if we take care of our patient for 12 hours, we might give them 3 insulin shots in the course of the day. So I wouldn't go to the right lower quadrant every single time I go do that. I would rotate around it. Okay, just a summary then of the sizes that we're gonna see, which are, again, they're just starting to sound familiar to us. We'll have more practice with them. And then sub-Q, so insulin is measured in units. Like I said, so maybe if they get 7 units of insulin ordered. And that's a very small amount. That is, so there's 100 units in 1 ml. So it's a very teeny tiny part, like, 0.7 of an ml, very tiny amount. Heparin and Lovenox does come in milligrams per milliliter, but it's always 1 or less. It's a very small amount. Okay, but that would be your max. Most drugs don't come close to 1 ml for the sub-Q route, but that tissue, it just doesn't have the capacity to take that much volume. So it would start leaking and it would be painful for that patient. Okay, so no more than 1 ml, but that is a lot. We don't see that sub-Q. Okay, we already said the angle, and then any injection we ever give, we're not gonna rub afterwards because it's just gonna affect how that drug is absorbed and distributed, could cause trauma to the tissue, so we would never massage a site afterwards. Okay, and rotating sites just means not in the same spot over and over again. All right, so that was sub-Q. And then intramuscular, the main thing we're ever giving IM is just vaccines. So your flu vaccine that you get annually, and then once you get over 65, we push the pneumonia vaccine. It's usually a once and done. Sometimes they'll get 2 sets of it. Okay, but vaccines is the main thing. And vaccines are all pretty much a 0.5 milliliter, 0.5 milliliters are standard. Okay, the other thing that we would give IM if it's not a vaccine would be like in the emergency department maybe, or in a psych unit. We might have a situation where we need to give an IM like anti-psych drug to calm them down. Okay, but on the med-surg unit, they have an IV. So we're not giving random IM drugs, we're using their IV. Okay, and then again in the emergency department, if it's a patient that for whatever reason can't or won't or doesn't need to stay and get IV antibiotics, but oral antibiotics are not strong enough to do the job, they could hit them with an IM antibiotic. Okay, so that'd be a strong, high dose IM antibiotic. That'd be very painful. Okay, but typically it's just vaccines that we're giving. Occasionally you'll see like a vitamin B that comes IM, you might see that in the hospital. Okay. So then our most common site is the deltoid. Okay, up in the arm is the main one that we're doing. If you work in peds, it's usually the vastus lateralis, the leg site that they do for the little kids. Okay, and then the least common is gonna be the ventrogluteal, the hip site. Okay, we used to do the dorsogluteal, the butt site, which was in my opinion best site because it's the most padding, but somebody must have paralyzed somebody and messed it up because we have some nerves that run through there, and if you don't use your proper landmarks, you could paralyze somebody. But if you use your proper landmarks, it'd be fine. But so we don't teach that anymore. The butt, the dorsogluteal, we don't teach that. We just teach these 3 sites. Okay, so deltoid, you locate the acromion process, right, which is that bone there that you feel, and then you should like visualize an upside down triangle, and then whatever is like the juiciest, meatiest part is should be the site that you go for. You're gonna have gloves on, right? You're gonna clean the site with alcohol, and then most importantly, always tell your patient to relax and just have their arm just like a spaghetti noodle, because if they tense it up at all, it hurts so bad. Okay, so tell them to keep it nice and loose, tell them to breathe because they'll hold their breath, and then right when I'm ready to do it, when I stabilize it, I pinch them really hard, and then they don't feel the needle as bad. Okay, so it's pain displacement, if you know like the gate control theory of pain. So if I'm already using the pain receptors by squeezing them, then they don't feel the needle as much. Okay, so right when I'm ready, I say relax, keep it loose, and then I pinch them and I do it really quick. Okay, and then I pull it out. Okay, so just make sure they relax. Make sure you have your gloves on, everything's clean, and then we just inject. Okay, so it can only tolerate 1 ml because it's not a very big muscle, but like I said, half an ml is what most vaccines are. Okay, and then the ventrogluteal site, we do that sometimes. It's kind of hard to find. Just make sure when you're using your landmarks, your hand goes over the greater trochanter when you're trying to find the site on this patient, which is the top of your femur. So if you have your patient bend their leg, or you or your friend, if you're practicing this, have them bend your leg, and then that's where you'll find the greater trochanter. So it's that top part there. That's where you put your hand, and then you spread your fingers along the iliac crest. And there's a picture that shows it better when we get to that. Okay, so you might do that site. It combines the hip and the booty muscles in that area. And then there's just some verbiage for how to find it. And then the last site is the vastus lateralis. It's just like the outer aspect of the thigh. So it's just basically the middle, right? So not the lower half, not the upper half, but just like the middle of their thigh, right in here. And like I said, if you have kids or siblings or anything, that's usually where you get all your childhood vaccines, is in your leg, until the deltoid gets big enough. All right, this is just kind of summarizing what I had said about the deltoid muscle. I don't think there's anything new. Okay, and then the ventrogluteal, there you can see, so the hand is over the greater trochanter, which is the top of the femur, and then your pointer finger will be at the anterior superior iliac spine, which is your hip there, and then you just spread your fingers out, and it'll be right between here. It's not a large area, so there's not a lot of wiggle room in there. So practice in lab or at home on your friend, see if you can find that site. Right, and then there's a picture of your vastus lateralis there, just that middle area. All right, again then, so needle length is gonna be based on your patient. I know when I worked at Fairhaven, like 20 years ago, Beacrest, I still remember this, I had to give an IM injection, but all we had were needles that were like this big. So that's what I had to use, but I only went in like that far with it. I just had to be really careful, because that's all we had. But in your hospitals and most of your sites, you're just gonna have exactly what you need. So be nice, always choose the smallest needle possible for your patient. With IM, it's always gonna be a 90-degree angle. All right, this here is an explanation of the Z-trap. The Z-trap is not something that we use often. I feel like in your book made it sound like we use it for all IM injections, but we do not. We use it few and far between. So only when we're giving a large dose and it's like an irritating medication. So back to that scenario, if we're in the emergency department and we're giving a large dose of an IV antibiotic that would normally be given over time in an IV, but for whatever reason this patient's like leaving out the door. So in that case, we would do a Z-trap, or maybe, what would be another example? If we're giving like an iron supplement, that can be very irritating, so we might do this. Okay, so all Z-track is instead of just like holding our site and giving it like we regularly do, we use the back of our hand and we put it on their skin and we pull back. So it just displaces the layers of their tissue just a little bit, so they're zigzaggy like that. Then we go ahead and put in our needle, inject the medication, pull it out, and then we let go, and those tissues will slide back, and they kind of seal that drug in. Whereas when we don't do that, we just have the skin, we inject, and we pull out. So if it was a large volume, it could come back out. With the correct amount, it's not, your tissues are gonna seal it. So by displacing it and then letting it go, it kind of seals it up with your own tissue, so it keeps that medication in place from leaking out. Okay, I've never been in a situation where I had to give a Z-trap medication. Okay, it's just gonna be in maybe emergency department or specific situations. It's only with a large dose irritating medication. All right, go through a few questions, and then we'll be done for today. We'll finish, this on Tuesday, and then we'll do, the dosage practice. We'll go through all of those, and then, finishing Tuesday and into Wednesday, there's an electronic health record activity. So we'll go into EHR Tutor and answer a bunch of questions about the patient's medications and come up with a care plan for her. All right, when administering a topical medication, you should use your bare hands, no. Apply the medication to clean, dry skin and wear gloves, that sounds good. Massage the medication vigorously, no. Apply the medication over a rash or broken skin, no. Alright, that one's worded kind of funny, but it's C. Okay, so aspirate, we'll talk about that while it's up here. So we've been talking a little bit about the word aspirate, and it has a few different meanings. So aspirate means to pull back. So we talked about it with tube feeds. So when we're checking placement, we aspirate to see if anything comes out. And also the liquid that comes out is called aspirate. Okay, so it's called aspirate, and then the process is called aspirate. It used to be taught for some injections that as we inject it, before we go ahead and give the medication and pull the needle out and get it over with, we would stop and aspirate. We would stick it in you and pull back on the plunger to make sure that we weren't in the wrong spot, to make sure that no blood came out. Which is so dumb that I never did it, even when they told me to, I never did it, because I knew it was stupid. But that's an old practice that they used to say you should do, but they don't teach that anymore. So we don't aspirate, we just do it quickly. We use our landmarks and we, choose the right spot, and we do it quickly. All right, 90-degree angle in all patients is what makes that wrong, because it's sub-Q, right? If it was an IM, that would be all, but sub-Q, it just depends on the patient. A 21 gauge needle to reduce pain is gonna be too small, it's not in our range. So it's just pinch the skin to lift the subcutaneous tissue. So your best answer should be B, rotate the application site with each new patch. Okay, this one is B. Okay, so we know A is wrong because I just told you we don't aspirate. Okay, that's an old thing. Inject into the abdomen, is abdomen a sub-Q site? Yes, it is. At least 2 inches from the umbilicus, which is the belly button. Does that match up with what I said? I said stay away from it. Okay, so I think that's right. C, use the deltoid muscle. Is the deltoid muscle a sub-Q site? No, it's an IM site. Okay, so that's why that'd be wrong. And then, like we said, we don't massage the site. Okay, that should be B. Okay, we don't recap them. Like I said, most of them have the needle protector. use them in real life. And a biohazard bag, is for anything with blood or body fluids and not a needle. Okay, that has to go in the sharps container. Alright, so we'll pick up here on slide, or dosage calculation, when we come back on Tuesday. We'll go through this. Okay, and I'll find out, I'll post something about the, break dues. And then I know I still have to post about your badges. Okay, so I'll be working on that. Unless people don't come.